This conference will now be recorded.
Okay, thanks, Jake. I think there's a few people, 2 or 3 people that might not have been on the call before. So let me see if I can just identify them. Gil, I don't think you've been on the call before. Is that right?
Yes, sir, that's correct.
Okay. And
Rich, if you remember, Gil was on Peter's call last week, and we talked with him and exchanged some emails last week after that.
yeah, I do. Yeah, I do recall that. But on this call, this is the first time on this call, right? Daryl, have you been on the call before?
I was on I missed last week with a family commitment, and I was on the first call. So,
that's right. Perfect.
Yeah,
yes.
So I would have been on the call, but just had a family commitment, and then I was busy with my November party and everything, so it was a bit crazy for last week.
That's right.
Back on track.
No, of course I remember. You were down in Florida, but last time you didn't have a camera, you weren't online.
I'm using my wife's iPad.
Okay, now we get to see you. Welcome back. How was Florida?
Yeah, it was great. 5 days, beautiful, amazing weather, and so all good. Managed to get 3 games of golf in, so all good. Thank you.
How was the golf? Dennis wants to know how was the golf, right, Dennis?
The golf was amazing. Yeah, amazing. We're going to get together, whichever guys want to play golf somewhere, sometime. Just have to figure out my treatment, and then we'll go from there.
That sounds good.
Great.
Hey, Dennis, do you think we could organize an ANCAN tournament? We could come up with a trophy, I'm sure.
I'll bring the trophy, don't worry.
There you go. I may make Dennis captain. ANCAN captain. You got to have a captain, right? You got to have a captain.
Right.
Okay. I could get my best buddy, who is this year's captain for the Guildford Medical Society, to participate in this too, because he's on our advisory board, so those guys are allowed as well. Dick Bailey, we're not going to be able to talk to. Is that right, Les?
Yes, that's correct. I can just fill in a couple seconds of who he is whenever you want to.
Okay. So yeah, we'll do that, and then we can just talk a little bit about his situation without him being able to interact with us. But we look forward to him interacting with us. And then Jim Kubat, is this the first time you've been on this call? I think it is, isn't it?
Sorry, I was away from the computer. What was the question?
Is this the first time you've been on this call?
Yes, it is.
It is. It is. All right. Well, you get to qualify, even though you're an old bee. You get to qualify as a newbie today.
I get it. All right.
Okay. Because I know who you are. Peter knows who you are. Gary knows who you are. Bill does, but the rest of the guys don't know you. So okay. So what we're going to do is we'll start off with Gil and Jim, and we'll talk a little bit about Dick Bailey, and then we'll run down and see who would like some time today. I think that covers everybody, right? So Gil, why don't you, if you're comfortable doing so, kind of go through the exercise you went through on Peter's group last week, where you just tell the guys a little bit about your situation. And I think that you're a neighbor of Rich Jackson, isn't that right?
We close to the same area part of the time.
Right. And you met Rich, and he suggested that you should participate in the group. Was that? Am I getting that right?
Yes, sir. That's correct.
Okay. Excellent. Okay, so fill us in a little bit about your situation and let's see how we can support you.
Primary care physician, ordered a PSA check, relatively new primary care physician. I've been going to him about 2.5 years, but he just recently ordered a PSA check, probably because I had some blood in my urine in the spring, which cleared up immediately. But he ordered that PSA check before I went in for my 6-month checkup. It came back at 55.7. I thought it was an error at the lab. It was 5.7. But he said he didn't think so, and he sent me to see a urologist. I really live in Florida, in the golfing capital of the world, probably, in a place called the Villages. And I went to a urologist there. He did a biopsy, did another PSA check. It came back at 74, which was about 3.5 weeks since the 55.7. We then did a biopsy. Biopsies came back at a 7, Gleason 7, 4 plus 3 for the majority. He ordered a CAT scan and a bone scan. My family situation, because I'm a 91-year-old mother and a son who's got 2 young babies and his wife is ill, forced us, my wife and I, to go to Virginia to support the family. So while I was up there, the doctor contacted me, wanted me in right away. I opted then to go to a local urologist in Virginia. He ordered the bone scans and CAT scans. Everything came back with no signs of any tumor metastasizing, except for my bladder. He couldn't get a good read. So he ordered another procedure to go in and do a cystoscope on the bladder, which was done last week. That was clear. He sent me to a radiology oncologist who went to go through what possibilities were out there that I could do. I listened to what he said. I've been doing research. I went to the a group meeting at Norfolk General Hospital. That's where I met Rich at that meeting. He was the one that pushed set the in to me, and that's how I got hooked up with you guys. Currently, I a doctor in Virginia, urologist. When I went back and had the cystoscope done, the doctor said that looked good, but so I asked him, what about just taking this thing out? And he said I was not a good candidate to have it removed. And the reason being that he, even though there was no signs in the scans, he thinks with the numbers as high as they are, there's a strong possibility some cells may have migrated outside of the capsule, and that if they took it out, they would probably have to go back and follow it with radiation anyhow. So his recommendation that I went with radiation. So he put me on a ADT pill, which I started last week. I go back in next week and have my first shot. And after that, I'm going to Hampton University to meet a doctor about protein. That's where I am currently.
So I missed the very last thing you said. You're going to see a doctor at Hampton about
Proton therapy.
About proton beam. Okay. As you know, Peter had proton beam, has had proton beam recently, not as primary treatment. And Les Shelderup, who's on this call, has had proton beam also not for primary treatment, but at least they can give you a little idea about proton beam. Many people on the call have had the IMRT plus low-dose brachytherapy. Whether or not you're a good candidate for surgery is, to me, a function of how likely it is that the disease, that you do have micrometastasis. And one way to get a handle on that is to to look at the Memorial Sloan Kettering nomogram. Has anybody talked to you about the Memorial Sloan Kettering nomograms?
No, sir.
Okay. So are you familiar with the concept of a nomogram?
No, sir.
Okay. So nomograms are large databases, usually from the same institution. And what they do is look at the outcomes for people that have had the same procedure. So it gives you a feel for what might happen if you had whatever the procedure is. Although, of course, it's not true that your outcome would be the same, but usually these databases are very, very large, so it gives you a pretty good feel with a pretty good margin of confidence. So one of the things I often suggest to people who are trying to decide whether they want to do surgery or not, and I don't know if if you want to do surgery, is to run the nomogram and to see how likely it is that you're going to need radiation afterwards. I would probably, just on the surface of it, looking at your numbers, tell you that what your doc tells you makes a lot of sense. When you've got a PSA that high, there's a good chance that you're probably going to need surgery. You're probably going to need radiation anyway. So why go through two lots? But I wouldn't necessarily rule it out without having maybe looked at the nomogram or gotten a better feel. It sounds like you seem quite comfortable with the idea of radiation versus surgery, though, at this point. Is that right?
Yeah, I'm more comfortable.
Okay. So is 55 the last reading you got? Or has your PSA moved since that 55?
74 was the last one.
Sorry, 74, I beg your pardon.
I haven't had one since.
You haven't had one since the 74. So specifically, I'll throw it open to the guys to talk to you. But specifically, what is on your mind? What can we help you with? I think I sent you the pamphlets for the hormone therapy and the radiation therapy, or the links to that. Did I do that?
Yes, sir. You did.
Okay. And so why don't you tell us what your questions are, and we'll throw it open to the guys.
Well, my question mainly is the BRAC that they talk about, this seed implantation after that. Some of the stuff I read talks about seeds dislodging, possibly migrating into the lungs, lots of different things along that line. Collateral damage with the IRMT or IMRT versus the proton is probably the biggest question I have about the collateral damage. What's the chances that I'm going to be wearing a diaper rest of my life? That's basically it. What's going to happen to this seminal vessels? Sexually, I'm not ever going to be able to perform again like I have. Those are all the kind of questions that are in my head. I read a ton of stuff, and it's all over the place. I think I got my handle on it, and then somebody says something different.
So let's just talk a moment about your biopsy. Did the biopsy indicate seminal vesicle invasion or not?
It doesn't mention it on the biopsy.
It doesn't. And did the biopsy indicate extracapsular extension?
It did not mention that either.
It did not. Perineural invasion?
Did not mention that either.
Okay. So I can talk to you from my own experience about IMRT and seeds. Yeah, I mean, I think that there is a risk of seeds migrating, but it is very, very, very low. I can't give you the number. I can tell you that I've been at this game, including my own diagnosis, since 2007, 11 years. I think I may have talked to one guy that had an issue with a migrating seed. I don't even think it had migrated completely, but I have to tell you, it's a pretty rare occurrence, and it was never even an issue for me in terms of a risk. In terms of side effects, first of all, unfortunately, nothing's scot-free. So whatever treatment you choose, you're going to be faced with some side effects. When you choose radiation, the one thing that we know is we're not going to have to resect your urethra, so you're not going to have to go through a temporary period of incontinence that will hopefully come back quickly. But what you might face is urgency, irritation, and I know, I think pretty much every guy I know who's gone through IMRT or brachy has had some degree of issue with that. But it's rare unless you've got some extenuating circumstances, like for example gene mutations, that you're going to have major issues from the radiation. In my own instance, I had irritable bowel syndrome before I went in, and so I've had some issues with fecal incontinence, but they're pretty minor. And there's things that you can do, and it sort of depends on the food that I'm eating, and I'm aware of it. I wouldn't say that it's a major problem, and it's certainly a hell of a lot better than the alternative. So while there are definitely going to be side effects, don't be an Eeyore when it comes to the side effects, and figure that you've got a very good chance of living a pretty much normal life, provided that we catch this in time, because that's been my case. I know that's what Rich Jackson's hoping for, and it does happen. So in terms of IMRT versus PBRT, again, I think I sent you the research, and I'm only aware of one study which did so far that did a direct comparison, although there is another study. There is actually a trial going on, but it's over a long period right now. And the one study that I sent you is a retrospective study, and the bottom line on that was that PBRT tended to have greater gastrointestinal side effects, and IMRT had greater side effects for the colon and the bowel. Excuse me, for the bowel as opposed to the colon, the bowel and the rectum. So with that, let me throw it open to the other guys and see who would like to talk to you.
Yeah, this is Peter. I spoke to Gil the other day on the phone, and I one of my recommendations is, I mean, if he had a 50% rise in PSA over 3 weeks, I think he should get a GU MedOnc on board. And I thought maybe, Rick, you might have some suggestions. I think he's down in the Virginia Beach area, so I don't know where the closest place for a good person is. I mean, it's not a place he has to go to all the time, but I think he needs to go beyond a urologist, because he's going to probably be dealing with something for a while. So that's my take on it.
Well, I mean, I would want to get a couple more data points, because it could be inflammation. We don't know. If there's certainly, that's why I asked, do we have anything since the 74? So it might be, when was that, 74, Gil?
First part of about 13th of October.
So about 6 weeks ago?
Yes.
Okay. Well, I mean, I think that, I think if you were with a single doctor and not having moved around like that, they'd be suggesting you get tested. So I would definitely say, if it were me, I'd want to get tested again. And then based on that test, it might be a good idea for you to see a GU med-onc. I mean, the fact that nothing showed up is a good sign, but there's no certainty from that. I think from where you are, I'd probably be going to Duke. That's where I'd be that's where I would tend towards. I think I said that to you in the in the note that I wrote back to you. Anyone else? Bill, what was your take on this? Because I know you spoke to Gil too.
Yeah, Gil and I already had a pretty long conversation. I gave him my background and what I would do and what I had done, and of course, going forward from here is up to him.
And if it were you, what would you be doing?
If it was me and his, I would probably do the same thing I did before. Is I would personally, I went ahead with the radical prostatectomy.
Mm-hmm. Mm-hmm.
But that was
Right.
me, and my PSA was a little lower than his, but our situation was similar. So
Okay. And who else would like to speak up? Who else feels that it's a good time now to see a GU med-onc, or would you see a radiation oncologist next? Would you be deciding between PBRT and IMRT? Some of you on the call, Len, what are your thoughts?
Well, I had difficulty hearing Gil describe his background, so I wasn't. I'm not clear on if there was evidence of spread beyond the capsule, like in the seminal vesicles or lymph nodes. But I'm assuming that since his doctor was not recommending surgery, that he strongly suspects he has some involvement in either seminal vesicles or pelvic lymph nodes. And maybe Peter and Les know more about this than I do, but at the time I was considering radiation, I was told that if you're going to have radiation to the prostate and the pelvic girdle, that PBRT was not an option. I don't know the technical reasons why, but now that was a couple of years ago. Maybe things have changed. But Peter or Les, do you know differently? Can they do proton beam outside if they're going to do the entire pelvic girdle?
I don't have an answer to that. I'll give Roy I can't remember his last name, but he just had primary treatment done with proton beam, and he has a Gleason 5-4 or something like that. I don't know I'll have to ask him specifically. I know they do a lot of California Proton does a lot of primary treatment for guys with prostate cancer, but I don't know the answer to that question.
So
I don't have a comment either.
So let me just clarify for you, Len, since you didn't hear that all of the scans that have been done to date and the tests have shown no hard evidence of any metastasis anywhere. I would definitely agree with Len that whatever you do, if it were me, I'd be considering pelvic girdle radiation, meaning radiation across the whole of your, across your hips, and not just radiation to the gland. To me, that would be essential. So that's something that you should be hitting on with whoever you speak to, and the radiation oncologist that you already spoke to, who was thinking of doing IMRT and seeds. I suspect he was looking at pelvic girdle radiation. Do you know? Did he mention that to you, Gil?
No, he did not.
Okay, so that's a question you should definitely be addressing with him, because I think it's probably important and a very good suggestion. Anybody else have any ideas? And would anybody be jumping to other than Peter, be jumping to a GU MedOnc at this point?
Hi, Gil. Hi, Gil. This is Rich Jackson. The only recommendation I would make is when you go to Hampton Proton, try to talk to Dr. Thornton. I spoke with Dr. Sinise, Christopher Sinise, when I went, and I think you'd get better information from Dr. Thornton.
And the other thing to be a little wary of, Bill, and I don't mean to offend any of the guys that have done PBRT, but our experience has shown that the PBRT docs try to sell you because they need the volume to pay for the equipment. It's true to some extent of the docs that use IMRT2, but it's very true of the PBRT docs. So if they're saying to you, well, yeah, if Len's right, and they say, no, well, we really can't do pelvic girdle radiation, but it isn't important. I would take that with a pinch of salt from what we know. The pelvic girdle radiation, the idea of it is to try and nail any disease that might have already spread beyond the prostate. So, you know, it is important, and there are studies that suggest that pelvic girdle radiation is essential. Now, neither Les nor Peter were using PBRT for the same purpose as you. And I don't know about Les, but I know that Peter, in his salvage radiation that he had 2 or 3 years back, 2 years back in San Francisco, did get radiation to his whole pelvic girdle. Are we confusing you? Is there anything you want to clarify with us?
No, sir. I'm not. No more confused than what I have been confused.
Yeah.
Okay, well, that's good.
I do have
One of the comments I have, Gil, is that you know, be wary of doctors that throw around the cure word. I mean, it is possible, but the probability of dealing with this at some level ongoing is pretty good for you because of you know what it sounds like. So don't get too optimistic if a doctor says, "Oh, we can cure you." Most doctors don't do that anymore, but some of them do throw that word around, and it sounds great, but it's not very realistic.
urologists made that statement, not cure, but he said that one of the reasons for that he didn't think I was a good candidate for the radical was that he felt pretty sure that even if they went there and took that out, they may have to follow up with radiation anyhow because some cells may have gotten outside with the numbers being what they are. Then that led me to the question of, he suggested the radiation plus the BRAC, and I can't find any information that says that you can actually get the proton and follow it up with BRAC behind it. I haven't found anyone anywhere that said that they have had proton radiation followed up with seed implants. So I don't know.
That would tie into what Len's saying, because usually if you're doing either brachytherapy or if you're doing brachytherapy, that is the radiation that addresses the prostate gland, and the rest of the radiation addresses the pelvic girdle. And so it might be that PBRT is not a good candidate for the pelvic girdle. I'm not sure of that either. How many biopsies have you had?
12.
12
No,
cores?
one biopsy.
One
one
biopsy.
biopsy with 12 cores.
One biopsy with 12 cores. And how many of those cores were positive?
9.
So 9 out of 12 were positive. And how much cancer do you know how much cancer was in the gland? How large the tumor lesions were?
No, I'll look for that. The only thing I had was the percentage factor of cancerous tissue on each core sample, in which 6 of them were 90 to 100%, and 3 of them were 25 to 55%.
Okay, so that's a significant amount of cancer. They should, somewhere on there should be some millimeter measurements. But what I'm hearing from that is that you're probably a better candidate for high-dose brachytherapy than you are for seeds anyway. Has anybody talked to you about high-dose brachytherapy?
No.
Okay, so you need, so you had a meeting with the urologist, and you've got a meeting set up for proton beam. Have you had a meeting with a radiation oncologist that does regular radiation?
Yes.
And do they do brachytherapy as well?
He's the one that said, first one that said that he thought, here's the different things that are out there, but in your situation that radiation therapy followed up with a brachy was with the seed implants, the way he put it, was the best thing for me, best solution for my problem.
Okay, well, I think, again, if it were me, I'd be wanting to talk to somebody that offers high-dose brachytherapy, high-dose radiation, which is where they insert radioactive rods, but they don't leave the seeds in there, because typically that has a better outcome where you've got a lot of cancer in the gland. So, most of the centers of excellence will do HDR now. In fact, more of them are doing HDR than are doing low dose seeds. So, just to sort of, because we need to move on to a couple of the other guys. So, just to summarize, Gil, I think the very first thing I'd be doing is getting another PSA measurement as soon as you can. And let's just see.
He's on ADT, though. He's on ADT already. So
Is that Peter? Peter, was that you? Or we couldn't.
Yeah, he's already started ADT, so his PSA is probably going to start dropping.
Yeah, he's on
Well,
bicalutamide.
He's done bicalutamide, so I don't know that I don't know that it will be dropping because that's an anti-androgen. What it's going to do is maybe prevent the cancer from feeding, but it's not going to be like so much like doing an LHRH drug. So I would get one anyway.
So, hey, Rick, don't you think going to someone like Dan George is not a great idea?
Well, this is what we're saying. I mean, to me, I think I think somebody like George would probably want another data point.
Hmm.
I mean, to me, there's not enough. We don't know. There isn't enough data to identify. And in today's world, the trend is to debulk even if you have metastatic disease.
No, I know that.
So, sure, exactly, because you finished up debulking anyway, even though you were metastatic. So to seek primary treatment now is probably not a bad thing to do. But more data points are needed. I mean, for example, the other thing I might want to do is get a better scan. Get an Axumin scan or a PSMA scan, and see if we can identify right now any clear metastasis. But then we still get back to the bottom line is even if we did, what would we do? How would that change the treatment? And it could, there are some doctors that might say, well, let's go forward with the radiation. And there are other doctors, if they saw metastasis right now, would say, no, let's do chemo or let's start you on a second line anti-androgen immediately. But I kind of feel like there's not enough information. And so to get an Axumin scan right now, or to get a PSMA scan and to get another data point is probably what I would be doing. And then based on that, I would, and also gathering more information. I mean, if it were me, I would not be doing LDR, I'd be doing HDR.
Right.
If I was doing radiation, I'd be doing IMRT and HDR. And one of the places you could probably find that is at Duke. So you could go down to Duke and you could get probably a PSMA scan or an Axumin scan down there, and you could see a radiation oncologist down there who would be give you a slightly different perspective. I don't think I'd be, if it were me, I wouldn't be looking at worrying about whether I was doing IMRT or PBRT. That wouldn't be my concern. But everybody's different. I would be trying to find out what the clearest and best treatment option is, and I don't know that you're there right now, Gil. Anyone else? So again, go ahead, Ken.
Yeah, all I would say is, sorry, all I would say is jump right on it, though.
Yeah. Daryl, do you have any thoughts? You're sitting there listening, you're pretty experienced.
Unfortunately, my journey didn't start like that, so I'm not able to really comment on other options. I am familiar with the brachytherapy and stuff, but in my particular case, it was just so aggressive at the time, and I just had to do the radical. So that was what I did, and I did the radical, and then straight after that, I did six weeks of radiation. Ultimately, it didn't really help because the the spread was the prostate already being compromised. So it was already in my system, and they weren't able to get it, I guess, after the radiation. All of it, which, as you know, eventually has now metastasized to most of my body. But in terms of, where Gil is right now, I never went through that experience of trying to make that decision. So I'm not that up on, what I would do at that point in time.
Jeff Dreyer this is closer to where you found yourself, isn't it? Although you had, I'm just looking, you had 15 out of 16 cause positive and some extracapular extension. Well, you right, you don't produce a lot of PSA, so that's a difference. Do you have any thoughts for Gil?
I am not sure I would be qualified to guess the specialist. I would leave it in the hands of, well, I mean, everything that's been said here, plus what the advice is given from your, contacts at the hospital. Yeah.
Well,
for my case, well, at this point, today I just actually met with a GU oncologist, a new guy at USCSF, Vadim Koshkin, who's a GU oncologist, and he really, well, I mean, I'm about 18 months into my
okay,
ADT.
Jeff,
Yes.
let me hold you. We'll get back to you. I don't want to talk about you and
Okay,
Vadim
sure.
now. Let's stick on finishing up with Gil. Okay.
Right.
So Gil, get some more data points. Look into HDR. See if you can get a PSMA scan, which would be, or an Axumin scan, which would give a much better reading on whether the disease has spread or not. And, based on that information, then you may want to talk to a GU med-onc. What we're trying to do is to get you to gather as much information so you don't finish up going through this process and then finding that there's something else you should have done to begin with.
Hey, Rick. Bill Franklin just posted a clinical trial comparing IMRT with proton beam. I took a quick look at it, and the inclusion criteria require essentially that it's local therapy. So T1, T2, PSA less than 20. So I'm thinking, go right ahead, Gil, and see the proton beam specialist, but I suspect they're going to tell you that you're probably not a good candidate for proton beam.
I suspect that's the one trial that's been approved, and it's probably a trial that's been out there for quite some time, I'm thinking. Because as far as I know, there's only one, the expert there's Alan Liddell. Anyway, we have to move on, Gil. Feel free to keep talking to us, come back to us. If there's anything you want clarifying, then get hold of either Bill or Peter or myself subsequently, and we'll clarify for you. But I think we've laid out a few markers that you can follow.
In the very beginning, you mentioned a database at Kettering. What was the name of that database?
That is, it's a nomogram, and hold on a minute, and I'll put the link. I'll put the link in for you so
Bill
that you can.
Franklin already put a link to it in the chat box.
Oh, okay, thank you, Bill. So if you look in the
Bill,
chat box,
if you can see the chat box, I posted it up there. It's the one with the MSK CC, which is Memorial Sloan Kettering. Can you see it?
I don't see it yet, but I'll find it. It's there. You
yeah,
can see the chat.
it's in the chat box window for you there. It's I
Oh,
think
yeah, I
the
see it.
first.
Okay. I got it. Thank you, Bill.
No problem.
Okay.
Thank you, guys. Appreciate you.
This is Jake. If you're given,
I'm cutting it off, Jake. I'm cutting it off. We've got to move on. Otherwise, we're not going to have time for everybody. Okay? Sorry. Jim Kubat. If you, Jake, send if you have something that's helpful, send a message in the chat window to Gil. Feel free. Jim Kubat. So let us tell you. In fact, I'm not going to tell you. I have the information. I'm going to let Peter tell you because Jim and Peter have worked together for 2 years now, Peter.
Probably, yeah.
And Jim is graduating from Peter's group, sadly, to our group. So why don't I let Peter introduce Jim, and let's see how we can help Jim.
Yeah, Jim had he's in Connecticut, and Len knows him too. He had an RP done a while back, and he's been monitoring his PSA, and it looks like he's got a low-level biochemical occurrence. It looks like it's not, his PSA didn't rise hugely, but he's been watching it, and his doctor, his radiation oncologist, felt that it might be time to move on it. I can't remember what the PSA was, but I think it was less than 2, wasn't it? I can't remember exactly. And anyway, but go ahead. So you've started radiation, I believe now, right?
Well, I've just finished the bicalutamide. That was 30 days of that once daily, and I had my ADT shot November 13th, so that's about 3 weeks ago. I'm starting IMRT radiation December 11th, so I guess that's a week from tomorrow. And they said that'll run until sometime early February. And Len Sierra, my doctor, is James Yu, who's a specialist in prostate cancer, and he was recommended from by the doctor that you recommended me to. I'm blanking on his name right now, but thank you for that, because yeah, that's a Petrolac. And so that's pretty much it. I think the main issue for me was the doubling. So I had the radical prostatectomy in August of 17. And then I switched from the traditional PSA test to an ultrasensitive in just this past February of 18, and that reading was 0.008. Following May, it was up to 0.019. July, it was 0.037. 2 months later, almost to the day, was 0.058. And then October 15, it was 0.103. So it's on the move, and Dr. Yu thinks there's an 80 to 90% chance that it's a recurrence. And he recommended not only that I do radiation, but that I do an aggressive radiation treatment, not just the prostate bed, but the pelvic girdle as well. And I got a second opinion from the Westchester branch of Memorial Sloan Kettering, and that doctor, Mahalchak, who I liked a lot, I would probably recommend anyone in that area to at least see him. He concurred with Dr. Yu, and he also suggested an Axeman scan. When I brought that up with Dr. Yu's resident, the resident said the Axeman scan would not pick up anything with such a low PSA as mine. So that's pretty much where I stand. I'm committed unless something comes out of left field that would indicate I should hold off. I'll be starting radiation next week.
Is Dr. Yu at Yale?
Yeah, that's at Yale New Haven. He's on the medical school faculty there.
Right. So Petrolak referred you within Yale. That's what I wanted to clarify.
Yes.
It sounds. I mean, I know that you've been diligently following this, and that they're creating some anxiety, which is not good. And so, in a situation like yours, it's probably a real good idea to dive in right now. How long are they suggesting that? Well, let me ask you, what was your post surgical Gleason score?
It was a 3+4.
Okay.
They thought it was a Gleason 8 going in, and then the pathology report showed it to be a 7. Although one of my cores from the biopsy was an 8. 1 out of 7 or 6 that were positive was an 8, and that was like 6 or 7 out of 17 cores. It was only 4% of the prostate.
Okay, so the post score that they gave you when they looked at the whole prostate was 3+4. Is that right?
That's right.
Okay. So I mean that's the key number. And by the way, and I forgot to mention this to Gil, but Gil, call us and we'll talk to you. It might be worth getting your slides read again as well. Just to make sure that you actually are a 4+3, or there are not other people that think you might be a 4+4 or higher, because it could change the amount of hormone therapy, the period of time you spend on hormone therapy. You can call me or Peter or any of us. We can talk to you about how to get your slides reread. It's a pretty simple process, and we can tell you where to get them reread as well. What question, going back to Jim, what questions do you have for the guys on the call?
Well, at this point, looking forward, I have three essential concerns, I guess. One happens to do with the word cure. It was interesting, the comments that were made before. I had my simulation last week, and after the simulation, I met with Dr. Yu and reviewed some things. And he said his goal is for a full cure. So whether or not that's realistic, it's at least psychologically comforting to even be maybe overly idealistic that it's possible, but I'm still holding out for that. Then the other thing is just the side effects. I think at this point, I've given up on retaining any kind of meaningful potency, but to slip back to an incontinence level where I was post-surgery would be annoying. I'm still, to a certain extent, incontinent. It's definitely been it's definitely had a negative impact on my quality of life. But it's now with the radiation to reverse some of the progress I've made with the incontinence. I mean, I've read about it. I know it's a possibility, and it varies from man to man. But any comments regarding how bad the incontinence might be? And I'm really hoping that I don't have any kind of rectal problems. That's only going to make things worse. But I mean, the urine I can handle. It just clips my wings a little bit, but I don't want to. I mean, I'm still working full time. I can't afford to have to run to a bathroom every 20 minutes. So,
what did Doctors Petrolak and you? What was their input regarding the incontinence? Did you discuss that with them in any detail?
Well, it's funny. They don't really go into detail. None of the doctors I've had so far go into detail on the side effects, and they often don't even bring them up unless I bring them up.
Okay.
But,
hold on a minute, Jim. When you go in and you speak to you, have you reviewed with him your history of incontinence?
Not in detail, to be honest with you.
So let me suggest this. Before you start, you need to do that. It's really important. It's not what the doctor wants to tell you, it's what you want to tell the doctor.
Okay.
You should be telling the doctor, these are my issues around it. He may not have a grasp of how much difficulty you've had with incontinence. And
I did tell the resident, and I was concerned lying in the bed.
Okay, you don't want to tell the resident, you want to tell you. He's your main man.
Okay.
And if you like, send him an email and put it in writing. You're very concerned. Why am I saying this? Because it may be that they want to leave you on HT for a little while until you have a better grasp on your incontinence, or they may want to work with you on your incontinence before they start any additional radiation. But if they don't understand that clearly and you haven't discussed it with them, it cannot be addressed. So it's really important on your part to raise these issues. It's really important on your part to get them to focus. I've said this on Peter's call, and I've said it many times on this call. Write out your questions and give the doctor a copy of your questions when you go into the meeting. That way the doctor's going to answer every question. Why? Because he doesn't want any liability. He's obliged to put those questions into your records. And therefore, he's going to address each and every one of those questions. Now, don't give him a list of 25 questions because it's going to piss him off and you're not going to get decent answers. But give him a list of 5 to 10 key questions that are really concerning you. And in your case, incontinence is one of those issues because you've struggled with it. And as you say, you don't want to go backwards. So you've got to be asking that doctor, am I going to have a problem with incontinence as a result of this treatment? And see what he says. Right?
Yeah, it makes sense. I tried to give Maholchak at Memorial Sloan Kettering a list of my questions, and he didn't want to see them. He just said, well, just read them to me.
No, and that's exactly why. Hello? Why do you think he didn't want them? Because if you read them to him, it doesn't go in your record. You have to say to him, here are my questions. I want you to take these from me.
Okay.
Right? That's exactly the reason why he didn't want them. And if you want your questions answered, you give him a copy of them. If you don't care what he says, or you don't want a record of it, ask him just verbally. It's simple. This ain't brain surgery. and you have to stick up for yourself. And if the doctor says, I'm not going to talk to you if I have to go through your questions, he's the wrong doctor for you. Everybody on this call, everybody, you got questions, write them down, give them to your doc. It's so elementary, so simple, and so important. You hear what happens when you don't. Jim's getting jerked around. There's no reason for it.
Yeah, I had a list of questions that I emailed Dr. Yu, and I never got a reply. So I just don't know how far to take aggressiveness with these people. And I can't. I don't know what to tell you.
Okay, let's talk about that, guys. How far should you take your advocacy with a doctor who's not that cooperative? This is a great topic. We may not get to everybody's questions today, but this is a hell of a topic.
And you need to.
How far do you go?
Well, I'll chime in about my shoulder surgery. When I had the shoulder surgery, I went to 3 different surgeons, and I had a list of questions about it. And I read it to all 3 of them, and I gauged their responses. And the guy who was the most engaging with me, who wanted to see my questions and wanted to answer all my questions, he was the guy I chose. Just flat out. One guy really seemed put off that I had questions. Like, I'm the doctor. I'll tell you what you need. Why are you asking me questions? The last guy I used, he was really open to any question I had. He wanted to answer all my questions. He wanted to alleviate any fears I had. That's basically why I chose him, and I think he did a great job. So, when it comes to the prostate side of it, I was very aggressive with a couple of my doctors, to the point where one of those doctors isn't my doctor anymore. So, but I kept my genitourinary oncologist. At first, I was going to drop him and move to another one, just because in the meetings he was very kind of abrupt. He'd come in, tell you what he wanted to tell you, and then he's trying to walk out the door as you're asking more questions. I finally just said, "Hey, listen, doc, I'm your patient. You're the guy with all the knowledge. I need answers. Will you sit still and listen to me, or else I'm just going to find another doctor?" And he sat down and listened to me. And now when I go see him, he sits down and listens to me. And I get out of my meeting with him, and I'm waiting in line to pay or something, and I see him with other patients. He's acting like he used to with me. He'll go in, tell him something, he leaves. And they look at like, oh, maybe I wanted to ask him something. I've told people in his office, you just got to tell him flat out, be still and listen to me. So that was my approach. And it turned out we have a great relationship. I think he's a really good doctor. He's got a lot of patience. He's not patient. He has a lot of patience. If you see the difference in the word I'm using, he's got a lot of people he treats, and he wants to tell everybody what they need, but he's often rushed. So, but I don't care if he's rushed. I need my answers. So my insurance company is paying him. So
who else has something to say on this issue?
I've got a similar situation with my doctor as well. I found him pretty rushed at the moment, and sends me in the doctor that's basically learning. And I had to the one day wait 3.5 hours to see him, and then I said, listen, I need you to send in my doctor, because I really have critical questions to ask him. And even when he came in, and I asked him about my situation of where I'm at now at this kind of late stage, regarding lutetium or actinium, and he was so vague to give me any particular answer. So at this point in time, I'm really on the fence in terms of staying with him, not staying with him, and that's why hence the information you've given me, Rick. I'm really going to be pursuing this week, and I've already been in contact with a couple of doctors in Vancouver and so on. But that's what I'm finding. If you don't self-advocate and really pressurize the doctor, you can be in trouble.
Ken Anderson, have you got something to say on this? Are you still with us, Ken?
Sorry, I
Yeah,
had my.
there you go.
I was talking away. No one was hearing.
We can hear you now. By the way, we've suggested to Daryl that he sees Dr. Korn. But why don't you give us your 2 cents on this issue?
As far as a doctor, now, don't put up with it at all. If you can't get their attention and they won't sit down and listen to you, send them packing. I mean, like you say, they have so many patients that they have to see during the day. You're lucky if you get 15 minutes of their time. And if they are, I mean, just send them down the road. I mean, that's all I can say is send them down the road. So
Now, Ken, you've advocated for yourself with Paul Korn. What's your experience been?
he's been an excellent, he's like you stated a zillion times, he's like the quarterback. And although he's not actually the one orchestrating, he's actually the one orchestrating the treatment, but he's not actually implementing it. So as far as I'm concerned, he's been just pretty excellent. In fact, tomorrow I go there. I'm leaving tomorrow to go to MD Anderson, and I'll see on Thursday after scans and blood work, and I'm sure he'll have something to say. But the fact is that I'll be confident in whatever that is. So
Right. Who else? Anybody else want to speak up on this issue of how far you should push your doctor to get full responses for your concerns?
Well, I'd like to talk to Jim a little bit. First of all, I think, Rick, what you said was amazingly insightful. You picked out the one thing that has been with Jim since the radical, and that's the incontinence. And so that he has to bring that up with the radiation oncologist. You cannot assume that they just get it. So I'm in the same situation with you, Jim. I met with the radiation oncologist, and he spent 40 minutes with me. He answered every question, and I did exactly like what you're saying, Rick. I brought this list of questions, and he loved it. He thought it was a great way of doing this, and answered every questions. And then he actually went into such detail, almost like he was enjoying being able to talk to somebody who actually knew what he does. So it turned out to be a real positive experience, and I really liked this doctor. So I really hope that, Jim, that you'll go in and make sure that he answers your questions. In my case, he gave me the exact numbers of people that might experience some incontinence or might experience some amount of fecal issue or some. I was worried about the stricture for me, and so he really went over all of the issues and explained all of it, and I felt very, very comfortable. So I hope you have time to do that with them.
Yeah. So Jim, when is the I didn't get it down. When is your surgery? When is your radiation supposed to start?
December 11th. So that's
December
next
11th.
Tuesday.
Okay. Well, here's what I think I would do if you can't get him to respond to email. You've got to either get in front of him or you've got to get a phone call with him before December 11th. And you've got to clearly address these issues. And if it is a phone call, email him your questions ahead of the phone call.
So let me just ask at this point, I had a list of questions and I did ask him. I asked him about the ED and I asked him about permanent damage to surrounding tissues and that sort of thing. And he was, it was responsive. I mean, he can't tell me, yes, this will happen. No, that will happen. But what should I ask him about the incontinence specifically? Is there something we can do to prevent it from getting worse?
Yeah, you should ask him whether you should explain to him clearly your history of incontinence, because it may not be well represented in your medical record. And you should ask him specifically, is the radiation likely to aggravate the incontinence? And would I be better going on hormone therapy right now and waiting until I have a better grip on the incontinence? And if you recommend that, who can I work with at Yale to help me with the incontinence?
Yeah. Well, I worked with the PT for 4 weeks on the incontinence.
Well, maybe you need to work.
I'll be right up front. I don't do my Kegels every day. I don't think, I mean, what will happen, Rick, is that I'd end up canceling Yale and I'd have to start with another hospital all over again.
No, you wouldn't. You might finish up. They may finish up and say, look, we've got some stuff we're doing with incontinence right now. Doing electrostimulation, for example, which there's a guy that does at UCSF, or we're doing acupuncture, or we're doing this, or we're doing that. And we don't think it's a very good idea to start the radiation until you have a better handle on it. I mean, what you don't want to do is finish up being radiated, causing permanent damage, and having to catheterize yourself for the rest of your life, right?
Well, I agree.
And you haven't even asked the doctor about that.
Yeah, I know what the answer will be before I even ask it. So I think what we're talking about here now, I'm gonna have to cancel.
Whoa! Since when are you a radiation oncologist, Jim Kubat?
Yeah, no, I get what you're saying. I really do, but I'm not optimistic I'm gonna get any kind of useful answer out of any of these guys.
Look, again, I want to move on because I want to try and get some time in for questions here. But Jim, you have to explain to your doctor about the issues that you have around incontinence, because they have been difficult issues for you. I've heard you enough times on Peter's call to know that this hasn't been an easy path for you to walk along. And if you haven't explained that in some detail to your radiation oncologist, and you're about to get a whole bunch of radiation, there's something wrong.
Yeah.
And you don't know what he's going to say to you. He may say, yes, you are a good candidate for radiation, and yes, we should start radiation, but you're not ready for it yet. Or he may say, I'm not going to radiate any area that is going to affect you, so don't worry about it. But we don't know the answer. And for you to sit there and say to me, I know what he's going to say to me, you don't know what he's going to say to you. And what we don't want is you ignore it, and 3 months from now you're telling us that your incontinence has gotten worse. So my obligation on this call is not to tell you what the outcome is going to be, because I don't know. I'm not an expert, but I do know how to navigate you. And to navigate you means ask the doctor what worries you the most about your future, which is having to wear a pad for the rest of your life, or being catheterized for the rest of your life.
Well, do you think?
And don't sweep it under the carpet.
But do you think he would he reschedule the radiation and push it back?
If he thinks he's going to do more damage, of course he will.
Yeah.
He
Jim,
doesn't think he's going to do more damage.
Jim, I'll speak up again because this is exactly what happened to me. I heard you say you worked with the physical therapist on your incontinence for 4 weeks.
Yeah.
I went for 8 weeks, one session, and then I went back for another 8 weeks, and I think I even did a third session, which was more than 8 weeks. I did the electrostimulation that Rich is talking about, and that helped me immensely. If you went to a physical therapist and all they did was teach you how to do Kegels, you didn't do enough, in my opinion. That's Bill Franklin's opinion.
But Bill, how did you know about electrostimulation, and how did you know that 8 weeks is better than 4 weeks?
The physical therapist, that was the script I got from my doctor. He sent me for 8 weeks, and the physical therapist did electrostimulation, the one I went to.
Well,
I went outside of the PT also and did my own research. I found a website with a process called Roll for Control, which is it's a little exercise ball and some elastic bands, and you basically exercise the muscles in your pelvic floor, which are what you're using to control your urine now that you no longer have that external sphincter on your bladder.
Right. Yeah, I know. I guess I hear, all of this is great. All I'm going to say is I will never, ever recommend Yale New Haven Hospital to anyone ever, because no one there ever tells me anything like this stuff.
And what I'll say, I've said to many people, Jim, is the doctors have a clinical understanding of the side effects, but you're going to be hard pressed to find a doctor who has a personal understanding of the side effects. Unless they've had prostate cancer, they don't know what we're going through. They know what they learned in medical school, but they don't know what we're going through. I would have loved to be treated by a doctor who already had prostate cancer, but I guess you could make that one of your criteria.
Well, I had two options for a PT who knew how to work with a man with radical prostatectomy, and I got one out of the two. The other one, I forget, wasn't covered or something like that. I thought she was good. She thought we were done after 4 weeks. I don't know what to say. I mean, I'm not a PT. How the hell would I know?
Right.
Okay.
I mean,
but one
I
thing
think I'm doing enough reading. Maybe I'm not doing enough research. I don't know.
One thing I hear from you is that you don't have confidence in Yale, New Haven Hospital.
Not anymore.
So why are you going to do your therapy? Why are you going to let them treat you?
Well, this guy came recommended. I thought that was good enough.
Yeah, but now you know it isn't. But hold on a second. But now you know it isn't. He came recommended. You're not happy with them. You don't have confidence in them, and you're going to start treating. And you wouldn't send anyone else there, but you're going to go get treated there next week. There's something wrong with this equation. Len, can you help me out?
Well, hopefully I can put an end to this whole discussion. If you guys probably know Patrick Walsh, world famous urologist, done thousands of prostatectomies. He wrote a book, Surviving Prostate Cancer. In that book, he states, if you go into radiation therapy with incontinence, you will lock it in. So, Jim, I think you should take the words of Patrick Walsh.
Well, yeah, I read Walsh's book before my surgery. I liked the book. I thought it was good.
Yeah.
I don't know, guys. Now I got to think of something again. This stuff is fucking driving me crazy.
So, Jim,
Petrolak recommended you. He said he was excellent. So, I don't know what to say.
Well, Jim,
your Memorial Sloan Kettering said, go ahead with it. I asked him questions about the incontinence. Geez, I don't know. I just don't know what to
Well,
say.
wait a minute. You said you didn't ask him, you didn't push him on the incontinence. You didn't ask him. You asked him about ED, but you didn't push him on incontinence. So, I mean, to me, there are a couple of things here. One is you got to have faith in your doctor. Either you do or you don't. You don't want to let a doctor do procedures on you if you don't have faith in that doctor, under any circumstances. Secondly, you've started your bicalutamide. You're going to get a Lupron shot. That's going to take care of holding this disease for a while. You now have to make sure you go to the right people and you have your incontinence under control before you start the treatment. Now, I will say that we're talking a little bit apples and oranges because Dr. Walsh was talking about primary radiation treatment and not salvage radiation treatment, I suspect.
No, it was salvage.
Oh, was it salvage?
Yeah.
Okay, then I stand corrected. And if it was for salvage and you've got incontinence issues, then you've got to get those incontinence issues under control. That's why I brought it up 20 minutes ago. That was the red flag that I heard. And that's why I've been pushing you so hard. Don't start your radiation if your incontinence issues are still not properly under control. I don't believe, and I'm just guessing, but I don't believe you really explored this with you, because I think that if you would have heard that, he would have said to you, you're not ready yet.
Uh-huh.
And I'm just guessing.
All right. Well, I'm going to bring it up with him. Yeah, no, I don't know what to say.
Well, what to say is find a doctor that you do trust. Don't write you off if you haven't given him all the information, because that's not fair. And as far as further treatment for your incontinence, we'll help you. We can guide you. Bill can guide you. Gary can guide you. I know a little bit about it. I can connect you to somebody who had very good success with electrostimulation needles, acupuncture. I mean, the points are in your feet. At least that's where my guy, Bill, were the points in your feet? Where were the? Where did they?
I did do acupuncture. The electrical
just
stimulation is
electrostimulation.
that's electrodes. They hook up
Right.
really uncomfortably close to your gonads, and
Right.
Yeah,
they send
not
current
your
through your
feet.
pelvic floor muscles.
Right.
Just trust that they know what they're doing.
Right. So that's
You weren't
another.
interrogated by the CIA?
No.
That's another treatment. What Bill's talking about, what I'm talking about, is some acupuncture points that they use. That one of the doctors uses at UCSF as the vice chair of the urology department. So this is not hocus pocus medicine. And let's get you sorted before you jump in. All right, we got to move on. Okay.
Okay, thanks for the feedback.
We have a lot of people on this call, and so I'm not sure how we're going to get around everybody, but let me run down and let me see how many people want to talk, and if it's something that you think might be able to hold over until next Tuesday, do so. If not, I can take the time to spend with you, and we'll run over. So let me start. I'll run down the list. Jake? No? Len? Anything for you?
I could speak, but I could also easily wait till next session.
Okay, so I'm going to put a little question mark down there. Ken Anderson, anything for you with respect to your trip to MDA tomorrow?
Nope. I'll just give a report.
Okay, thank you. Rich Jackson, anything for you?
Nope, I'm under control at the moment. Thank you.
Great. Bill Franklin, anything for you, sir?
No, I'm good. Thank you.
Okay. Daryl, is there anything you'd like to review? I mean, we have Ken Anderson on the call who's seeing Dr. Korn right now.
Yeah, I think what I'll do is, if it's okay, I'll give Ken a call on the phone and go through it, so I don't have to kind of give everybody the situation here, just to maybe give me some advice as I navigate this next phase. But I really am interested in this lutetium and this actinium, and I just did a bone scan last week. Rick, I think you got my email that
Yes,
I
I
sent
did.
you.
Yeah.
That
Yep.
unfortunately the bone scan was not good, and right now it's besides being my my ribs, my pelvis, my spine, my my neck, and it's pretty much everywhere now. It's actually moved from to my sternum, and also in my femurs, in my leg, the metastasis.
Right.
So it's kind of everywhere, and the more I look at this right now, and I can feel the pains have increased. So I'm now taking kind of 2 milligrams of Dilaudid at night, no other meds.
So let me stop you, because we will come back to you. We'll spend a little bit of time with you before the end of this call.
Thank you.
Dennis, anything for you today?
Nothing, Rick. Thanks.
Okay. Don Price, is Don Price still with us? He's so quiet, that Don Price.
I am hearing nothing from you, Rick.
Do you have it? You're so quiet always. You know. Is there anything you wanted to talk about tonight?
No, thank you, Rick.
Okay. We have a caller who hasn't identified. Is there somebody on the telephone who hasn't identified themselves?
Hi, Rick. It's David. I jumped in late.
Okay, David. Is there anything important for you tonight? Is that David Bowles?
Yes, it is. Yeah.
Okay, we have a couple of Davids. Anything for you tonight?
Nothing's popping up in my head right now. I know I did email Bill. I had a question for him, but it's probably not pertinent to any conversation here. So I'm waiting for him to get back to me.
Yeah, that's Bill Burhan's Bill Franklin. That's Professor Bill we're talking about.
Can't see.
Okay. Let me keep going down this list. Jay Curran, anything for you tonight? Jay Curran?
I think he dropped off.
Okay. Les, anything for you tonight?
Not for me. I was going to introduce you to this Richard Bailey, but since he can't speak tonight anyway, it probably doesn't help him much. So I'll pass.
Right. And Dick Bailey, I'm so sorry that we're running out of time tonight, but join us next Tuesday, and we'll try and figure out a way that we can talk about your situation. We would be happy to do that. Where am I? Paul Frieda. Paul?
I think he's gone too.
Okay. Shref, anything for you?
No, just listening.
Just listening in. Okay, good for you. I'm glad that you're on the call. Gary Gumville, anything for you?
Rick, thank you. I didn't call in for myself, but I really wanted to listen to what Jim was saying, because we both are going through a similar situation. So I just really wanted to be there to support Jim. And
Thank you.
And I would like to throw out the last thing that if it was me, I would want to have that Oxyman scan, no matter what they said. That's what I would say to him.
Okay. Sylvester, anything for you?
No, thank you. I'm comfortable. Thank you.
Peter, anything for you?
No, nothing tonight.
Okay. Jeff Marchi, anything for you?
No, I'm just fine, thank you.
Good. Good. Those hot sweats under control?
Yes, in fact, I got my doctor to hold off my shot for 2 weeks from the 6 months exactly. Had my blood test the day before I had the next shot. My PSA was less than 0.01 and my testosterone was 20, even though I'd gone 2 weeks past the week. Had my 3-month shot instead of a 6 month to see if it will help. The Depo-Provera has not let up much. I get a slightly warm at times, but I'm doing great. So
Good.
I like to hear about other people's experiences. I'll tell you that Gil, I mean, his case seems urgent to me. I mean, his PSA is going up rapidly. He's got such a high percentage of cancer in his cells. This guy's got to move quickly. He's got to get those tests and get it done. But
Okay.
that's all I got to say.
Thank you. Thank you. Larry Fish, anything for you? Larry, you still with us?
He's muted.
Okay. He'll be back with us at some point in time. I'm pretty sure. Jeff Dreyer, I think, dropped off. So why don't we spend a little bit of time with Daryl and with Len, and then if we do have any time at the end, we can come back to Les. And I want to thank all of you for holding your questions till next week. We will definitely give you anybody that had something this week and didn't and held it back. We'll give you priority next week. Daryl,
Yes.
please. Just give the guys because some of them don't know you, give them a 3-minute and then let's hone right in on what's bothering you and where we can direct you.
Okay, journey 6 years, radical prostatectomy, radiation, docetaxel, immunotherapy, and again radiation to my neck. So at this point in time, the metastasis has pretty much spread everywhere, as I was telling you guys earlier. But at this point in time, I can definitely feel that the pains are getting worse, especially in my ribs and my hips, my pelvis area. And I'm looking at doing this lutetium or the actinium. My biggest issue right now is finding out whether I'm a candidate and what basically I should be looking at doing, whether it is a lutetium or the actinium, either in South Africa or in Germany. And Rick kindly sent me all those that information last week, which I will now be working on. I'm just confused as to which doctor I should really speak to, whether it's the docs here in Vancouver or your connections with Paul Kahn or your connection in Great Britain. I'm a little bit confused as to where to go, and maybe if it's just phone calls, I'm not quite sure how these doctors would take if I just emailed them, or if they would need my whole file, or really where to go from here. So I'm in a bit of a quandary at this point in time to really work out whether I should do lutetium, whether I should do actinium, whether I should do it now or later, or and for me, quality of life is very important. I have trips planned to go to Florida. I have trips planned to go to Australia. I have my Ride to Conquer Cancer coming up in June of next year. So I've got a lot on my plate while I'm thinking about doing these various treatments. So that's really where I'm at, guys. Thank you.
Well, I think I'd like to defer maybe to Ken Anderson, because Ken's talked to Paul Korn about the lutetium. I don't know that any of us here can really give you any guidance on whether you should be doing actinium or lutetium. That's a little bit above our pay level, but you know what I think most of us would say that if we were in your situation, we would be doing exactly what you're doing, which is pursuing some sort of radionuclide treatment. And one of the reasons why I refer you to Paul Korn is because, as Ken has said, and will tell you more, he's not only super smart, he's very, very compassionate, and he's very interested in you and your head and how you are. And it's unusual to find a doctor who, and he takes time with you. He was diagnosed with metastatic cancer like you. We got him down to Paul Korn. I recommended to him, and so did one of Ken's other friends. And Ken, I'll let you take over.
And you get an answer to that. You could have said, you know, yes, you know, they could, you could compare.
Ken, are you there?
Yeah, I'm here. You know, I have to admit though, I don't have any like first-hand knowledge about lutetium or actinium. I don't know Paul's take on either one of those, although we are going to talk about it this next week. I'm going to be there in fact, with him on Thursday. So, I mean, as far as getting an appointment or sharing information with him, I think he'd be fairly open to an email. Okay. I mean, I'd share his email with you, and you can send him kind of a little outline of where you've been and what you've been up to and how your treatment's gone so far. I mean, he's very, very compassionate. I will, and I can no doubt, because traditionally what I do is I'll record our conversations, and I'll be happy to share so you can kind of hear how he addresses this treatment.
We need to mute Jim Kubat.
Thank you, Ken. That would be amazing. I appreciate it.
Yeah, I mean, I listened in, Daryl, to a conversation, a 10-15 minute conversation that Ken recently had with Paul. And I mean, it will certainly give you a terrific feel for this guy. And he was actually talking to Ken on this conversation about accessing the radionuclides. I thought Ken had actually spoken to him specifically about what they were doing. I mean, they are doing a test. They are doing a trial at Anderson, are they not, Ken? But it's 2-to-1, so
Correct.
there's only a 66% chance. You know, my feeling on that, Daryl, is if you don't get it, you leave the trial and you go somewhere where you do get it.
Yeah, it's very interesting that I think in Vancouver they are starting to do this lutetium trial, and it's actually coming to Toronto. From what I understand from Prostate Cancer Canada, it will be coming to Toronto in the beginning of the new year. So okay. that's just lutetium. So what I'm not sure about obviously is whether I do lutetium first, or do I just go and do the mighty blast of the actinium either in Germany or in South Africa at this stage of the game. You know, your body can, I guess, only handle so much. I am pretty strong at this point in time and active and so on and so forth. I'm concerned if I do the lutetium and it, let's say, doesn't work, how will I handle the actinium, or should I just go and do the actinium and you know, go for that, because that's kind of my last shot at it. So you know, those are the questions I would be asking the doctors, you know, what they suggest I should do in my case.
So, I mean, you clearly know more about it than I do. I mean, I didn't realize that that you could even do both of them. I thought that they were kind of mutually exclusive. I have a couple of thoughts. One is that I will connect you with Alan Edel, who is probably the most savvy. He and Tony Crispino are the two most savvy advocates in the country with respect to these types of treatment. And they're both advocates, but they're very, very knowledgeable. They serve on or Tony serves on SWOG, and they're incredibly knowledgeable. So I'll make sure that I connect you to them, because they may have a better feel for the lutetium actinium trade-off. I really don't, I'd be very interested to learn more about it.
That would be incredible. Thank you.
So
Daryl, this is Peter. You mentioned you're going to be traveling to Australia. I thought Jim Marshall said that they've been using lutetium there for several years in Australia.
Yes, they have been. They have been.
Yeah.
They have been doing it.
And how open? Is that a possibility? They have a lot of experience with it and success.
Yeah, they have had. It's been sporadic in terms of the results, but I look at it as that we are all a fruit salad. We are not all apples, and if it doesn't work on one person, it may work on somebody else. So in my particular case, my prostate cancer is a bit of an anomaly, because as we've gone through this before, my PSA right now just went up slightly to 2.59. And, with the metastasis that I have, I should be 1,000. So, this is one of the anomalies. And also when they did my genetic testing, they actually couldn't find a prostate gene. So, it's not like I'm a regular case. So, maybe these doctors would actually find this quite interesting, and hopefully, try and assist me in getting around to a particular treatment at this point in time.
Yeah, well, I think I'll come back to Australia in a second, but I think that's why Korn is such a great doctor for you. I mean, we referred him a spindle cell case. Unfortunately, it was late, but he was creative, he was compassionate. And I think your case is the sort of thing that he would get his attention, and that's why I'd like to see you talk to him. The Peter McClellan stuff in Australia, I mean, that's where the lutetium results were published last year, and it was a small sample. Do you remember how many, Daryl? Was it 20 something?
I don't remember, but it was very small.
It was small, and we knew one of the guys that was in that sample used to attend it regularly. But again, he waited late before he got the lutetium treatment,
and did he not make it?
He didn't make it.
He didn't make it.
So, but he was very sick. Hold on a minute. Just hold on a second, Ken. I'll come to you. Let me just finish. He didn't make it, and I think he went in a little bit late. Ken, go ahead.
Yeah, I'll ask Cam on the numbers as far as that trial was concerned. But I also want to state that I agree that MD Anderson in general, because of the rarity of the type of low volume disease, I think they'd have a huge interest in at least talking and discussing kind of what you're doing and where you're going and why some of the stuff's worked and why some of the other stuff's not worked, and whether or not their lutetium trial is open at the moment, I'm not sure. I'll know more on Thursday, so I'll be able to share it next Tuesday.
That would be amazing.
So what we'll do is this: we'll send you I'll send you Paul Korn's email.
Okay, thank you.
And please tell him that.
I'll send him an email.
Okay, thanks, Ken.
Thank you,
Yeah,
Ken.
Yeah, Ken will send him an email. He'll tell him that you're coming through us because he knows me, he knows Ken.
Thank you.
Obviously, he knows Ken. And then you can send him an email and just put in some of these details
I will do that.
and figure out whether he wants you to come down to Houston or whether he'll see you on the phone. But I don't think it would be a wasted trip to go down to Houston.
I would jump on the plane tomorrow if that's the case.
Okay, he's really good. If he thinks he can help you and see you, he'll get you in quickly.
Incredible.
I mean, I've seen him do it. I say that because I've seen him do it.
Thank you.
Les,
if you could just give me a heads up when I should email him after you've spoken to him, that would be great. Thank you.
Ken will get an email out to him tonight, and I'll get the information up to you, and you can probably write to him tomorrow.
Amazing. Thank you, guys. Thank you.
Len, what's on your mind?
Well, first, just quickly, can I ask Daryl, did you already have Zofigo?
Did I have what? I'm sorry?
Zofigo, radium-223.
No. What happened is about a year ago, my doctor asked me if I wanted to do the radium-223, and I declined it because I read an article that if you do radium-223, you will not be a candidate for lutetium or actinium. So I declined it at that point in time, and it doesn't help soft tissue. It only helps bone. And with the metastasis that I have in my neck and my mandible and so on, it wouldn't have helped me. So I did decline that at the time, and I'm happy I did because I wouldn't be a candidate for this right now.
Right.
Thank you.
Good choice. Okay. Yeah. So Rick, just a quick statement. Doesn't need to be discussed. Sadly, after 20 months of drug holiday on ADT, it looks like I'll be going back on. Just had a PSA check today, and it's continuing to rise. So when I see Dr. O, probably within the next week, I'll be back on some form of ADT, something I'll discuss with him.
So to give us the numbers.
Yeah, so let's see. I would say it's doubled in the past 6 months from close to double, 0.43 to 0.80.
Okay, so the numbers that you got today was 0.80, because I know the one before was 0.65, correct?
Yes, and that was just a month ago.
Okay, so and how long have you been on the drug holiday, just for the benefit of the guys on the call?
20 months.
Okay, so which for those of you who are thinking about intermittent hormone therapy, that's what you can get out of it. It's you're going to have to go back at some time. We didn't talk much and follow up much with Jim Kubat on the issue of cure, but there's no such thing as cure when this disease comes back. And it bothers me that the doctors talk about cure. It's a question of managing it for the rest of your life. And Len has done that in an exceptionally smart and good fashion, and he's gotten 20 months. That's the good news. The bad news is he's got to go back. And one of the things that I had said to Len, not on the call, but written to it, I'd like, if it were me, I would be talking to Dr. O about Alila monotherapy, because most of you who are on this call heard Al Fat a month or so ago talking about the success he's had just doing Erleada, and the doctor that prescribed the Erleada is the same doctor that Len sees. So Len, I think it's worth asking him whether he thinks that might work for you, because its monotherapy would not include LHRH.
Yeah, I'm definitely going to.
Len, this is Peter. I probably don't even need to say this. Hello? I probably don't even need to say this, but you might want to ask Dr. O about the gallium-68 before you go on back on therapy. 0.8 is where I did mine last February, and that's where it picked up my spots. So,
and Peter,
gallium-68 is perfect at that point.
Yeah, I would definitely do that, but there's not enough time to schedule it because in 3 weeks I'll be heading down to Florida. So the last time I met with Dr. Rowe, we decided that if my PSA went up again, he'd put me on some form of EDT, and then when I came back in April, I'll probably go off, let the PSA rise, and then I'll have the scanning done.
How long were you on ADT before you stopped it for 20 months?
Well, probably for a total of about 20 months, but it was broken up by another round of intermittent therapy. So it was 7 months, one period, 13 months, and another period.
And then 20 months off.
20 months off.
So, I mean, again, we have thought, and Len has thought about the gallium scam, Peter, but to accommodate his travel and his winter plans and everything else, he and Dr. O are thinking get on some form of hormone therapy, and then we'll do some examinations when you come back in April, and that's that works. It's going to peg the disease for a while, and hopefully we'll get a better handle. Len will get a better handle on where the disease is actually recurring in the spring. Len, when did you say that you're seeing O?
I don't have an appointment yet because I just got the result today. So I'll give the office a call tomorrow, see if we can get it scheduled.
Okay. And the purpose of that is to determine what type of hormone therapy you're going to go on for the next 3 or 4 months.
Exactly.
Right. One thing I want to just mention to you, because people forget about this, is after intermittent, when you go back on, if he does say that you're going to use an LHRH, make sure it's Firmagon, or otherwise make sure you're taking bicalutamide first, just like when you started originally.
Yeah. I'll recommend 1 round of Firmagon, drive the T level down right away.
Right.
And then either Erlita or Zytiga.
Right. So, but if he thinks that you're a candidate for the Erlita monotherapy, you may not even do the LHRH unless you want to do it.
Yeah, it's something.
The LFAT method. I don't know how he gets that leader. I put something on Mike Scott's website, and of course he gave me a thorny response, which I've now come to realize that whatever you post on Mike Scott's website, you get a thorny response, and it really doesn't matter who you are. So I don't take it personally anymore. I remember going back to Ruben. Do any of you remember Ruben, my friend Ruben, who was on our calls years and years and years ago, and he would get so upset with Mike Scott? Sadly, he passed away because he got diagnosed with stomach cancer, and he didn't last very long, but he would get so upset with Mike Scott on Prostate Cancer International because his responses were always a little ornery. is there anything on your mind, Len, that we can answer, or anything you want to ask us in advance of your appointment with O?
No, I don't think so. I mean, I know what we're going to talk about, and I have a lot of confidence in Dr. O. So,
Okay.
yeah, I'll report back to you guys what he says.
Jake, anything you want to say to Len? You. Yes, you.
No, not really. I like the idea of trying the Erlita monotherapy, Len, if you'll go along with that.
Yeah.
You know,
Yeah, I'll talk to
then
him
you don't
about
have to worry about then you don't have to worry about your testosterone either.
it. Right.
Because I know you're Mr. Macho with a high testosterone already. So if you take the LHRH, you're gonna get a big zap probably, and that might cause you problems. So I definitely like the idea of trying the Erlita if you're a candidate.
Yeah. Well, the fortunate thing for me is I've never had a big problem with the ADT as far as side effects go. I mean, obviously loss of libido, all those things, but I don't get any sweat. I get probably just the typical fatigue, nothing debilitating. I don't get depressed, so I'll be okay.
How's your head right now?
It's pretty good, Rick. It really is, because as you mentioned, we all know ADT doesn't work forever, particularly with me. I'm a Gleason 9. I'm shocked that I managed to stay on drug holiday for 20 months. So this has all been a big bonus.
Okay.
I'm
All
in a
right.
good time. Yeah.
All right. Well, Len, let me know when you. I'll talk to you tomorrow, but let me know when you get the appointment with O. Guys, we're only about 5 minutes over, and I'm sorry if people called in hoping that they could discuss particular things today. It didn't happen, and but we have another meeting next Tuesday. Len doesn't know this, but I don't know if I will make that call because I've been invited to visit the Foundation Medicine Lab and to serve on their patient advisory board. And so they're flying me to Boston next Tuesday. And I honestly have no idea where I will be when the call is on. So if I can call in, then I will. And if I cannot, then Jake and Len and maybe Peter, if Peter calls in, will handle the call very well, I'm sure. And I'll do my best certainly if I'm waiting for a plane in Atlanta to jump on the call. If I don't speak to you, it'll be 2 weeks today that I will, but most of you know you can get hold of me if you want to. The last thing I do, two last things, two things I want to mention. If you didn't read the email, the advance notice, and you want the PCRI, you want to go through the PCRI discs, you need to send your name to Len, who's going to coordinate that. The system we're going to use is we'll send them out to somebody, you keep them for about a week, and then we'll let you know who you have to mail them on to. And Len very correctly pointed out to me that if you participate in this and you lose the discs, then there'll be a $150 fee to replace the discs. So we hope that everybody will be responsible and we'll get the discs around. pretty well. Anything else you want to say about the discs, Len?
Yeah, I already talked to Jake, and I was going to send it to him first because there's a lecture that's particularly interesting to him. But now that he heard he may have to pay 150 if he loses them, I don't know if he still wants them.
Do I have to sell my mattress again already?
That's right.
Or my new computer?
Sorry, what are these discs about?
Prostate. Go ahead, Rick.
No, you explain.
All right. So, have you heard of the Prostate Cancer Research Institute annual conference, Daryl?
No. Yeah, I haven't. No.
Okay, so it's the largest patient-centric prostate cancer conference in the world. It's held annually in Los Angeles in September.
Right. Okay.
And the organizers invite the most interesting and talented medical oncologists and urologists to lecture to prostate cancer patients who number close to 1,000, the ones that attend. And it's a series of lectures over a period of 2.5 days. So we have the DVDs of all of the lectures.
I see. Thank you.
Yeah.
Marguerite attended 2 years ago. She attended. So, and I'm pretty sure somebody spoke about lutetium and actinium this year. Was it Mac or was it somebody else? I can't remember.
I believe it was Kwan.
Right. If anybody wants them, Len, do you want to give your email over the air?
Sure. It's LENSCAC@gmail.
LENSCAC@gmail. And just drop Len a line and you'll get on the list, and then you'll hear from Len as to how you get them. And please don't sit on them too long, and then you'll be responsible for mailing them to the next guy.
So Rick, I have a couple things I'd like to. I'll get on, but I'll send you an email. But I'd like to know Daryl's contact information, so when I send this off to Paul, that I'll know, other than just Daryl from Montreal, who he is.
From Toronto. So, Rick, would you forward that on to the Daryl Lemberg? You've got my email address.
I'll send it to you tonight, Ken.
Thank you, Ken. Thank you, Rick.
Okay, and to those who are celebrating Happy Hanukkah, I have to light my candles. I didn't have time to light my candles before the meeting started. Otherwise, I would have swung the camera around and shown you. They're right behind me, but they're going to get lit in about 10 minutes.
I did it for you before, Rick.
Thank you very much, Daryl. Thank you.
We need all the miracles we can get.
Isn't that the truth, my man?
And I hope it lasts more than 8 days.
You are spot on.
Yeah.
You are spot on. All right, I think there was something else, but we run on long enough, and I'll try and be on the call next Tuesday, and I'll speak to you all very, very soon. Oh, I know what the other thing was. We are going to get a fundraising. We're about to do our annual appeal for the end of the year. We only do it once a year. So please don't trash that email when it comes through. Open it, read it, and just work us into your end of year charitable giving plan, please. That's my appeal.
Rick, can you send me the information regarding what this is all about for these funds?
Yeah. I mean, it's basically to expand these groups, and it's to maintain ANCAN.
Oh, okay. So I'm not really familiar with ANCAN. Where do I look that up? Because
ANCAN.org.
And can.org. Okay, perfect. And congratulations on being offered that wonderful opportunity to go to Boston.
Oh, thank you very much.
Kudos to you.
Yes.
Thank you.
Congratulations.
Thank you.
Well deserved.
Thank you.
Fantastic.
All right, guys. That's it for tonight. Otherwise, there'll be no one left on the call but just the four of us. So we'll say good night now. Good night.
Thanks,
Good
guys.
Good night, everybody.
Appreciate it. Cheers,
Have a
guys.
nice weekend.
All the best. Cheers, boys.